but sorry, Dr. Carlson. It's my pleasure to introduce today's speaker, who comes to us from OHSU, where he's an associate professor in the Department of Orthopedics. But background is in physical medicine and rehab. So he's going to be talking to us today on non-operative management of hip and knee osteoarthritis. Thank you, Dr. Carlson.
Thank you very much. I was concerned OHSU and Providence weren't compatible, but we're actually up and running now. So first off, disclosures, I am a medical consultant for Standard Insurance here in town. I've been doing that for several years now, and will review cases regarding impairments. My specialty is physical medicine and rehab, and a lot of what we do is function. I originally did this talk for a rheumatology meeting in the winter, so you're going to see a lot of ski pictures. And the focus of this is on non-operative management of osteoarthritis. We're not going to talk about joint replacements. We're not going to talk about the surgical treatments. When I'm having a conversation with patients about how we can treat their arthritis, I usually tell them that we've got three major areas of management. We've got conservative treatments, we've got minimally invasive treatments, and we've got surgical treatments. And surgical treatments are very good treatments for osteoarthritis, but the focus of this talk, we're going to take the surgical off the table and really talk about our non-invasive and minimally invasive treatments. So to get started, we're going to go over some epidemiology. And let's get that out of the way. With the mouse. Maybe we're not compatible. Yeah. All right. All right, we'll get through this. All right, we're going to talk about epidemiology, pathophysiology, what's actually going on with osteoarthritis, and then we're going to get into the management. When we talk about management, we're going to want to talk a little bit about the etiology or what's really causing osteoarthritis. And then I'm going to take a little bit of a side trip, and we're going to talk about models of osteoarthritis. And this was kind of a light bulb moment for me when I read this article on biomedical versus biopsychosocial models. And we'll talk about why that's important when we get to exercise and why exercise is an important treatment for osteoarthritis. So epidemiology. Osteoarthritis is the most common form of arthritis in the US. I think we all know that. It's a progressive degenerative condition, and we want to be careful when we start talking about that because that means something to patients, especially when we talk about the biopsychosocial model. We know it results in pain and impaired ability to perform activities of daily living. It's also the leading cause of disability in patients age 65 and older. 20 million Americans have arthritis. It increases in prevalence after age 50. 85% of people over age 65 have radiographically evident arthritis, whether they have symptoms or not. So lots of people have evidence of arthritis on x-rays, but they may not have symptoms. Annual societal costs, these are numbers from about 10 years ago, 95 billion. Getting closer to home, 40% of Oregonians are projected to be older than 50 by 2040. And 44% of Oregonians over 50 have arthritis. So what is the pathophysiology? So we've got the picture of our healthy knee joint and then our arthritic knee joint. And we know that osteoarthritis is characterized by several things. We start to lose the articular cartilage, so that cushion between the bones. We start to get joint margin bone formation. So essentially these are bone spurs that start to occur. And we start to get synovitis. With this thickening of the joint capsule leads to a restricted range of motion. That's usually accompanied by muscle atrophy. That's associated with pain. That's associated with stiffness. That further restricts motion. And that leads to more functional impairment. So it's a little bit of a downward cycle. What are the management options we've got short of joint replacement? We can kind of put these in several different categories. We've got all sorts of medications that we can use. Non-steroidals, inflammatory analgesics, things like Tylenol or Tramadol, corticosteroids, injections. We can use viscosupplementation injections, or we can use corticosteroid injections. There's several different studies that talk about patient factors and things like patient education and self-management programs, weight loss and joint protection programs. We have all sorts of orthotics and assistive devices, and actually some of the biomechanically most efficient orthotic and assistive devices are pretty simple things that have been around for a long time. Things like canes and heel wedges, but we've got some more high-tech carbon fiber braces and things like that we can use. And we've got exercise, and exercise can be all sorts of things, but generally I will talk to patients about exercise in three categories: strength, endurance, and range of motion. So I want to take a little deeper dive into each of these. And if we start with medications, we'll then move on to bracing, injections. There we go. We'll talk about something that probably none of you have used for arthritis. And then we're going to focus on exercise. And for the non-operative management of osteoarthritis, I tell patients I think exercise is the mainstay of what we're doing. So this was a nice randomized controlled trial review looking at knee osteoarthritis and looking at medications. They took 80 randomized controlled trials, and they looked at what was most efficacious in treating pain with knee osteoarthritis. They found that acetaminophen was better than placebo. They found that acetaminophen was comparable to low-dose ibuprofen or naproxen. That non-steroidals were also better than placebo. That 16% of the studies showed differences in efficacy of the non-steroidals. And interestingly, Atidilac seemed to work better than the others in 50% of these studies, greater than 50%. And Atidilac is one of those kind of more GI-friendly non-steroidal anti-inflammatories, kind of before the COX-2 inhibitors came out. So that and Nabumetone, or Relifen, is another one that seems to be somewhat effective, and you don't have as much trouble getting the insurance companies to approve it. We're always asked about glucosamine and chondroitin. This was the GATE study, which came out in 2010. They looked at 2-year outcomes of glucosamine plus or minus chondroitin sulfate versus placebo versus Celebrex. What they found was that no treatment had a clinically important difference in WOMAC. So WOMAC is it is a self-reported function and disability scale for knee and hip osteoarthritis, and it has pain and function scales. And there was no difference versus placebo with the glucosamine and chondroitin. It seemed that glucosamine and Celebrex had some beneficial effects, but there was nothing that met significance in terms of trends. And from a safety standpoint, there were rare adverse effects. So we think these are very safe medications. We're just not sure they're efficacious. And I always talk to patients about cost. If they're spending a lot of money on it and they don't feel it's doing any good, probably stop taking it. If they want to give it a trial, I'll usually tell them to go to Costco or someplace where you can buy a huge bottle of it for $10 and see how it works for you. The other advice I give patients is that when my dog, who's a Labrador Retriever, had hip arthritis, I gave him glucosamine, and I don't know if it made the dog feel better, but I felt better about it. Bracing is something that has been around for a while. This is kind of a newer type of knee brace. When I say newer, what we used to do was heel wedges. And heel wedges are a great tool for changing the angle of the knee joint. And I don't know the exact year, but I'm going to say probably 20 years ago, people started using unloader knee braces. And the idea of an unloader knee brace is that most people, when they get knee arthritis, generally tend to get one compartment or the other. So usually more medial compartment than lateral, although you can have more lateral than medial. But the point is you have a good compartment and a bad compartment, and you can offload the bad compartment onto the good compartment. So these are usually 3-point braces that you're essentially, think of it as a teeter-totter, that you're unloading the bad compartment to load the good compartment. There's been a couple of nice studies looking at the biomechanics and efficacy of these offloader or unloader knee braces. And they do show that mechanically you can decrease in this case, they were looking at medial knee osteoarthritis, the medial compartment load, that was associated with decreased pain and increased activity. Knee braces only work as well as a patient will wear them. And body type plays a role in the knee brace. People that have a very cylindrical leg, thigh and calf, fairly similar circumference, a little bit easier to fit with the brace. People that have a cone-shaped leg, bigger thigh, smaller calf, a lot of times they're going to find that that brace just kind of slides its way down the leg. So you can actually do the same sort of unloading with a lateral heel wedge for medial knee arthritis. And a good orthotist can set that up very easily for a patient. And for some patients that either insurance won't cover these braces, they're not inexpensive, or they don't have the body type, or they just don't want to wear a brace, sometimes going back to the old school heel wedges can actually be a very useful tool. We tend to do a fair amount of knee injections. High hyaluronic acid is something that is certainly been around for a while now. And we know from some large studies that it can be efficacious. This was a nice meta-analysis of 57 trials that they looked at in 2003. Of those 57 trials of knee arthritis with high hyaluronic acid, 22 met their inclusion criteria. 17 of the 22 were industry sponsored, so we have to kind of look at that. And it showed that there was a modest efficacy in treating knee osteoarthritis. Now, when these injections first came out, they were a series of injections, and they started as a series of 5 injections that you would typically do a week apart. And then they said, well, maybe 3 is also adequate. And then at least one product on the market now has 1 injection. So essentially, you've put a whole bunch of your high hyaluronic acid in one syringe, and you inject once as opposed to multiple times. But the real question is, how does it do versus corticosteroids? So when they look at hyaluronic acid versus corticosteroid injections, and they took 100 subjects with knee osteoarthritis and randomized them to either 3 injections of the hyaluronic acid or one injection of corticosteroid, they found that when they looked at the WOMAC score, the Knee Society rating, and the visual analog pain scales, no difference in pain or function at 6 months. So clinically in my practice, if somebody really wants a corticosteroid injection, I'm going to do or if they want an injection, I'm going to do a corticosteroid injection first. My feeling is it's significantly less expensive. The efficacy seems to be about the same, and you can get by with 1 injection as opposed to multiple injections. If they get good relief, but it's short-term relief, a couple of weeks, I might consider doing a series of high hyaluronic acid injections to see if we can get longer-term relief. If they can get 5 or 6 months out of it, then maybe that's worthwhile, and maybe they're just not a responder to the knee corticosteroid injections. This is probably one of the treatments that you have not done. there are actually studies looking at leeches for knee osteoarthritis. So this was an interesting randomized controlled trial. They took 51 subjects. They gave them a single treatment of 4 to 6 leeches on the knee versus diclofenac. And they found that leech therapy actually decreased pain at day 7 compared to the non-steroidal. So, we're in Portland. Maybe this is something people would want to do. Well, let's go back to what causes osteoarthritis. And we talk about primary osteoarthritis, and really the etiology isn't clear. It probably has to do with aging. It probably has to do with heredity. But it's not exactly clear. We have a little bit better sense of secondary osteoarthritis. So that can be osteoarthritis due to inflammatory conditions. That can be due to trauma. We know that fractures around the joint line or significant meniscal tears can make a difference. And then we've got this thing called repetitive stress. And this is something that's always very interesting because it goes to a lot of advice we give patients in clinic. And we'll tell patients, if you've got osteoarthritis, you probably shouldn't be out there doing things because you're just wearing that joint out further. So one of the things I've always been interested in is physical activity in osteoarthritis. And it's interesting when you go into the literature, because as you go into the literature, you can find lots of articles that say that physical activity is associated with an increased risk for osteoarthritis. The more you do, the more arthritis you're going to have. Notice the names of the researchers here. If we go into the literature, we can also find studies that say physical activity does not predispose individuals to osteoarthritis. So I want you to pay attention to the names of the researchers because the same researcher that has articles that says it causes osteoarthritis also has articles that say it doesn't cause osteoarthritis. So it's really hard to know what advice to give to patients when they say, I really like to run, but I'm getting some knee arthritis. Can I go out and run? Or doing any of these kind of more physical activities. So I don't know the answer to this. But I do know that once the cat's out of the bag, that once the patient has osteoarthritis, there are numerous articles that show that people that exercise have improved function and decreased pain. So when that patient's coming in and they've got osteoarthritis, we can point to lots and lots and lots of studies that say that exercise is a very, very useful and important tool for treating osteoarthritis. It goes back when I was in my residency, and this was in Boston. The CEO of the hospital, who was a cardiologist, he would say, somewhat tongue-in-cheek, it was always hard to know with him, that you're born with a certain number of heartbeats, and exercise just makes you wear them out more quickly. Which we all laugh at, and we say, no, exercise is good for your heart. But we've got that same sort of feeling with osteoarthritis, right? That you're born with a certain number of cycles on these knee joints and hip joints, and that if you're going to use these joints, you're going to wear them out more quickly. When I've talked to one of our cartilage researchers at OHSU, he's kind of the belief that there's probably a sweet spot in terms of exercise and cartilage health, and that too little exercise probably is not beneficial for cartilage. Way at the upper end of too much exercise probably isn't beneficial, but somewhere in the middle probably is beneficial for that cartilage health. So we're going to get into some of these studies and talk about what happens when our patients have osteoarthritis and we put them into exercise-focused studies. Before we get there, I want to talk about this article I read several years ago, and it was, again, this light bulb moment for me about how we treat arthritis, and frankly, being in physical medicine and rehab, I see a lot of back pain. You can take this to disc degeneration and spondylosis and all the rest. And what the article said is that it's this biomedical model of osteoarthritis. And this is kind of what I was taught in medical school. And it says pathological characteristics of osteoarthritis impair normal anatomic function, and that leads to pain and disability. And that this pain and disability has physiologic impacts. So those are things like decreased muscle strength, decreased endurance, decreased joint stability. And we've got this other model which says that the biopsychosocial model of osteoarthritis, while there's pathological characteristics of osteoarthritis that can be perceived as pain, it's much, much, much more complex. That pain behavior and disability is a product of our beliefs, our understanding, our experiences, our emotions. Those are all things that we can influence in the clinic and with physical therapy and things like that. And as we modulate those, that can actually make an impact with our patients. So when we think about the pain and disability of osteoarthritis and these psychosocial impacts, it includes things like ill health beliefs, helplessness, decreased self-efficacy, passive coping strategies. Oftentimes that combines with inadequate social support in our elderly patients. If we think about the ill health beliefs of osteoarthritis, this is what people think when we tell them you have a degenerative joint disease, that it's inevitable, it's incurable, and it's untreatable. I hate the term degenerative disc disease or degenerative joint disease, and we're trying to get our radiologists not to use that because our patients will go read their radiology reports on Epic, and they'll come in and say, I've got a degenerative disease. And really what we're telling them is you have gray hair. Your joints are getting older. And how you frame it makes a difference, and that goes back into that biopsychosocial model. So patients believe, because of these ill health beliefs, that we have activity-related pain, and that's indicating damage. Helplessness is another one of these biopsychosocial impacts, and we know that it's associated with increased pain and depression and disability, and that it's fostered by this chronic nature and poor understanding of the cause of osteoarthritis. Does exercise cause osteoarthritis? Does activity cause osteoarthritis? Can I do these things? Self-efficacy is an individual's confidence in their ability to perform tasks that achieve specific goals. And we know that increased self-efficacy is associated with increased activity levels, less pain, longer perseverance with challenging tasks. We all have patients with passive coping strategies, which means that they're going to rest, avoid activity, and abandon responsibility for pain control to others. Probably a lot of you say, yep, that sounds like patients I see in clinic. Active coping strategies are associated with better pain control and less disability. And then social support can promote a lot of things: physical, social, emotional well-being. And again, if we think about who gets osteoarthritis more frequently, it's our older population, it's wear and tear. And that social isolation in the elderly kind of combines with this age-related increase. So the quality of social support tends to be very, very important in how we treat osteoarthritis. So why did we take this side trip? Because the biomedical model does not adequately explain what we commonly see in clinic, which is some individuals come in and they have really significant arthritis, and they really have minimal pain and disability. And we have other patients that have really minimal radiographic findings and have severe pain and disability. This biopsychosocial model much better explains this weak association between the joint damage and the pain and disability, and why some individuals react differently to the same intervention. So the reason I wanted to go through there is we're going to go back to what's our mainstay for non-operative conservative management of osteoarthritis. It's exercise. And why is exercise our mainstay? Because there's truth to the biomedical model. We do have these physiologic changes that occur, and exercise addresses those physiologic changes, like increasing strength, and increasing endurance, and increasing flexibility. But exercise also addresses the psychosocial impacts. So when we get patients exercising, they're promoting appropriate health beliefs. They're promoting active as opposed to passive coping strategies. We're disrupting that fear avoidance behavior pattern, and we're enhancing their self-efficacy. And this reduces their helplessness. And how we set up programs, group exercise programs are great for kind of decreasing that social isolation, regardless of the age of the population. So let's make a case for exercise. These are two quotes that I really like. These are both by physical therapy researchers. The first says that the psychosocial benefits derived from exercise are as important as the physiologic benefits. And this one I really like, says exercise may be the most effective, malleable, and inexpensive modality available to achieve optimal outcomes for people with osteoarthritis. So let's see if we can prove that. So this was a nice study looking at knee osteoarthritis. It took 102 knee OA subjects. They were randomized to a 2-month walking program versus a control group. And they found that the intervention group had significant improvements in walking distance and functional status compared to the control group. So they told patients, you can go out there and you can start walking and you can exercise, and they actually found that they did better and they had no increase in pain compared to the control group. This was another nice study looking at knee osteoarthritis. Interestingly, it also had 102 subjects, different authors, so I'm assuming different subjects. They were randomized. So the first study was walking or endurance type exercise. This study was randomized to a 4-month isometric or dynamic resistance training versus control. And what they found was the resistance training group had significant improvements in functional tasks, stair climbing, with decreased pain compared to the control group. This is probably the best study I've seen for knee arthritis. This was Edinger out of Wake Forest. They had 439 knee osteoarthritis subjects. They described them as having mild to moderate knee osteoarthritis. They were randomized to a 3-month resistance program or to a 3-month aerobic program versus a control group. And then they enrolled them in a 15-month home-based program. The exercise groups did not matter whether you were doing resistance or endurance or aerobic exercise. They improved their function, they decreased their pain, and they improved their disability scores compared to the control group. What do you think happens so they had a 3-month, very organized, come in, meet with the therapist, do a group therapy class 3 times a week, and then they said, go off on your own at home, and we want you to keep up with this for 15 months. What do you think happened with exercise compliance? So exercise compliance drops off, symptoms come back. Hip osteoarthritis, we don't have as much good studies. It suggests similar results for hip osteoarthritis, but most of the studies look at knee and hip together. So we have a hard time kind of teasing out the hip arthritis versus the knee arthritis. And these weren't quite as well controlled in terms of what they did with the exercise program. These were kind of more generalized exercise and education programs. So if we look at some of these studies, 105 knee or hip osteoarthritis subjects, 6-week education with exercise group versus control. They met weekly for 2 hours. They did 1 hour of exercise a week, which is not a ton of exercise. And they had moderate improvements in their pain and quality of life scores. No difference at 6-month follow-up. So get them out of the structured program. Our kind of usual lifestyle habits get back, and everything returns back to the baseline. Similar study. This had 201 subjects. They had knee or hip arthritis, randomized to 3 months of exercise versus a patient education treatment as the control. Interestingly, one exercise protocol used for both knee and hip. In general, when we're prescribing exercise, we're going to be specific to the joint. We want to strengthen the muscles around the joint. The exercise frequency was not standardized. And what they found was that, the baseline characteristics differed, so it was kind of a little bit of a tough to get information from the study. They found that exercise was associated with reduced pain and disability at 3 months post-intervention. At the 6-month follow-up, no significant difference between groups. So compliance drops off, symptoms come back. So it gets to a tough question we have if we're advocating exercise for any problem. How do we get patients to adhere to exercise programs? And we know this is kind of a very complex problem. And part of it deals with perception of personal capabilities. And we know that when we get patients started with exercise, that 50% stop within the first 6 months. Increased adherence is associated with positive attitudes towards exercise. So what's the best exercise out there? This is a question I always ask my patients. Anybody want to take a crack at it? Walking. So I hear walking. How many, show of hands, walking? All right. Any other options? Swimming. Okay. You are the correct, yes. So the correct answer is the one that they will do on a regular basis. So if I have a patient that loves to run and hates to swim, and I tell them, oh my gosh, you've got knee osteoarthritis, you've got to stop running and start swimming and do something that you're not going to have any effects of gravity, I'm going to take somebody that was exercising and turn them into a non-exerciser. So the big thing I tell patients in terms of what exercise is the best exercise, it's the exercise you enjoy doing. Now, if you're having enough pain with running, we need to have some talks about what we can do. And, this is where triathlons came from because people were wearing out from their running and all that. But taking somebody that really likes doing something and convincing them to do something else, in my experience, is generally not a successful outcome. Patients should have a sense of control over exercise. It's one thing to tell the patient you need to exercise, but if you don't give them instructions and teach them how to do that, you're probably not going to be very successful. It's like somebody can tell me, here's how you change the transmission on your car. I'm not going to know how to do it. If you walk me through it, I could probably do it. Also, lower levels of confusion. So again, we want to teach people appropriate exercise, how to exercise, and how to move on with exercise. So if we look at some studies, and these are kind of interesting, these look at exercise adherence and compliance. This study looked at 102 sedentary, another study with 102 subjects. They did a home-based resistance training program, and they identified adherence factors. And what they found was that physical factors were the indicators for overall exercise participation, but it was the psychological factors that were the indicators of adherence. So you could get patients to get started with an exercise program based on kind of our biomedical model, but if we want to keep them going, we need to kind of pay more attention to our biopsychosocial model. This was another study looking at exercise adherence. They took 114 middle-aged subjects. They assigned them randomly to a 5-month exercise versus control group. The exercise group had a self-efficacy intervention. So they were taught how to be in control over their exercise program, what to do, how to advance it. They weren't given just exercises. They were saying, here's how you take care of it on your own. And what they found is the exercise information group had higher adherence and decreased attrition over time. So keeping patients exercising, we've got to spend a lot of time in how we do that, and that means what do you like to do? When are you going to do it? I always tell patients, I think it's great if you've got social support. So get a workout partner, get a workout buddy. As an example, I've got a brother that works at OHSU with me. We used to run, I still do, he doesn't, but we used to run at 5 o'clock 3 times a week, and we'd meet at OHSU and go take a run, 5 a.m. I told him when he'd go on vacation, I said, don't tell me when you're on vacation. Because if I know you're not going to be there, I'm sleeping in. So having that kind of peer support, we can call it peer pressure or peer support with kind of an exercise partner, I think is really important. For most patients, I tell them get out of the house. I think it's tough to do it's tough to stay compliant with a home exercise program. Some patients can do it very well, but for most of us, by the time we're home at the end of the day, I've got so many other things to do. The last thing I'm going to do is go work out, and by 10 o'clock in the evening, it's like I'll do it tomorrow. So do things you like to do, get an exercise partner, get some peer support, do group exercise classes, and if you can, get out of the house. So before we go, I just want to credit Ray Atkinson for all these great ski pictures. This is kind of a neat book that he'd put out for those of you that are kind of long-term Oregonians who probably remember the Oregon books that he had put out, but some really nice pictures. And then I wanted to show some of my ski pictures. So I did my internship in Cooperstown, New York, which is up near Lake Placid. This is the 70-meter ski jump, so you can go up to Lake Placid and go up on the jumps. This is looking down from the 90-meter ski jump. So this is what the ski jumpers actually look at. You can see the 70-meter off to the right, and you can actually jump off the thing. All right. Thank you very much. Any questions? Yes, sir. Yeah, so obesity and arthritis. I think we all know that there's an association with obesity and knee arthritis. It's interesting, when we look at the studies of hip and spine arthritis, there's not as clear-cut a association, but definitely with knee arthritis, obesity goes hand in hand with it. The problem is, so to me, I think it's a little bit of a cop-out when our patient comes in and they've got arthritis and we say, well, you got to lose weight. And then, go out the door, go lose weight, we'll see you later. If they could lose weight, they probably would have done it by now. They probably know they need to lose weight. We can talk to them about that it's going to be beneficial for your joints if you can lose weight, but we also, again, need to give them some control over that situation. So if we've got resources in terms of losing weight, and the other thing I always tell patients, if you're going to lose weight, kind of the equation is take less calories in and burn more calories off, right? So it's a combination of diet and exercise. I think diet plays that bigger role, but it's a combination of things. So I try to help them get set up with a program that, yes, losing weight would be beneficial, but hey, we all know there's people that aren't overweight that have arthritis. That's not the only cause of what's going on here. But instead of just tell them you're a bad person and you need to lose weight, let's give them some resources. And let's make sure that exercise is a component of that. Even if you don't lose weight, exercise is still going to help with your strength, your endurance, your flexibility. Function tends to be followed by pain. So it's another important thing to tell patients. If we're going to start an exercise program for your back problem, your knee problem, your hip problem, don't expect changes in pain in a couple of days, in a couple of weeks, in a couple of months. I'm going to tell patients I expect that your pain may start to improve maybe 6 months out. Now, if I'm thinking 4 or 5 months, I'm still going to tell them 6 months, right? Rather have them happy that it happened early than say, why hasn't it happened yet? But pain tends to be associated with function. When joint function improves, when you can increase strength, endurance, flexibility, that's when pain improves. So the other analogy I give them is I tell them it's like training for a marathon. You don't pick a marathon next week and say that's the one I'm training for. You pick one 6 or 9 months down the road. That's the type of time frame we're taking. Patients could come in and say, I did 4 weeks of therapy and it didn't help. It's like drop in the bucket. That's not enough time to actually tell. Yes?
What's your effect of partial meniscectomy on the natural history of osteoarthritis, and does it increase the risk of ultimately needing a total knee?
So the question, I missed the very first part, but what's the effect of a partial meniscectomy on knee osteoarthritis, and does it increase risk for needing a total knee? So it is interesting, back in the old days, the 70s and things like that, people would have a meniscal tear and they'd get their meniscus taken out. And they take the whole thing out. And there are studies looking at those people that had their entire meniscus taken out. And those people have very, very severe arthritis at this point. So the meniscus does play a protective role in terms of the cartilage. There are some canine studies that have been done where they'll trim a little bit of the meniscus off and then look at kind of the pressure that then develops on the cartilage, and they find that it does, even taking a little bit of the meniscus off can significantly increase pressure on the cartilage. Now, when I talk to our cartilage researcher at OHSU, he says that some pressure is good to help kind of maintain blood flow to the cartilage. What most of, at least our orthopedic surgeons are doing, and I think most orthopedic surgeons are doing, is if they do go in and they need to trim a meniscus, they're taking the least amount they need to take. So meniscal tears are interesting because if you look at studies of people that have no knee pain and you pull them off the street and you do MRIs, what percent of people with no knee pain have meniscal tears on MRIs? I heard 20. Depending on the study, anywhere from about 30 to 50%, which is similar studies with rotator cuff tears in people that don't have shoulder pain. And the studies of disc degeneration in people that don't have back pain, it's 30 to 60%. So, and who do you find it in more? as you get up in the older age groups, you're going to see more of these changes. This is normal wear and tear. So to me, the real key on meniscal tears, if you get an MRI and you see a meniscal tear, it's not necessarily the tear, it's the company they keep. So the patient that has the meniscal tear and has a little bit of pain is probably less likely going to get a scope at our institution than the patient that has a tear and has locking, buckling, catching, sticking, these mechanical type symptoms. So it's kind of the company it keeps, and you know, I think you want to be very prudent and know your orthopedist well and say, you know, is this somebody that really needs this, or can we get by without it? Ours tend to be fairly conservative. I think most are. Yes.
Thank you very much. Really great lecture. A couple of questions. When you were talking about the comparison of knee injection, hyaluronic acid and corticosteroids, it's curious to me, is there data about the immediate comparison to the two things? You know, if they look at what was happening after 6 months,
Yeah.
and I'm just wondering if one's better for knee release. And then the other thing is, are there harms? What harms have you seen reported in the literature in terms of studies of corticosteroids?
So the first question is there data looking at immediate relief with high hyaluronic acid versus corticosteroids? And then the second question was, what's the harm, presumably with repeated corticosteroids, but potentially with individual? Right. So I'll say right off the bat, I can't quote you any studies, but I can give you a kind of anecdotal experience and kind of the way we practice. I think that if patients are if you're looking for quicker onset of relief, I think you go with a corticosteroid injection over the high hyaluronic acid injections. My experience when I do a series of high hyaluronic acid injections is that, you know, every now and then a patient will tell me they're doing better after injection 1, but usually we need to be getting out to injection 3 or something like that before they're getting better. So if somebody says, I've got a trip next week and can we inject the knee, I'll say, let's put some lidocaine and cortisone in it. Interestingly, as I recall, when the first 2 products I can recall in the market, first was Synvest and then the second was Supartz, and Supartz kind of marketed theirs that it caused less immediate pain than the Synvest seemed to be more irritating than the Supartz. So again, presumably they had some studies, but some people will get some irritation with the injection. We definitely, and I think everybody knows this, but we don't want to do repeated corticosteroid injections too often, too frequently. Kind of the dogma out there is no more than 3, some people will say 4 injections per year per joint. If I had a young person with some knee, 30s, 40s, they've got some knee arthritis, I would be very concerned about putting corticosteroids in that knee every 3 months for multiple years. Now, I do have some patients that are in their late 80s and 90s that have severe knee osteoarthritis, that have cardiac and other medical problems, that a knee replacement is just not in the cards. And I have done repeat corticosteroid injections. I usually tell them I don't want to do more than about 3 a year, but they'll get scheduled. And if they get good function and if it carries them over and it's increasing their activities of daily living, I will do it. And I think the risk, long-term risk, is outweighed by the benefit in that patient population. But I do think you need to look at the patient population. Yes, sir.
I wonder if in the Leach study, the benefit at 1 week was because they were promised a double dose and it didn't help.
It was interesting. Apparently, so they talked about the Leach saliva. Did the Leach study work at 1 week because the patients were told if it didn't work, we're going to give you a double dose of leeches, which would seem like an effective way to do it. But I had to go look at it. It's like, what's going on here? And they talked about leach saliva has some sort, 2 things. One was an anticoagulant effect. So interesting, but maybe not pertinent for the knee osteoarthritis, but also it has a little bit of a local anesthetic effect. And, I've never had a leech on me, but I've watched movies. Stand By Me, right? Isn't that the one with the leeches and all? but people seem like not to be aware. They come out of the water and it's like, oh my gosh. So I think they felt that there was some local anesthetic effect that may have been taking place with that. Yeah. In the back here.
How much does the hyaluronic acid cost nowadays?
You know, that's a great question. I don't have an answer. Does anybody know how much hyaluronic acid costs? I know it costs enough that about every 3 weeks we get emailed by somebody that says don't use hyaluronic acid, right? I mean, it's harder and harder and harder to use it. Again, my first choice is almost always a corticosteroid injection. If they get relief, but it doesn't last very long, and I'm usually thinking weeks, I think it's reasonable to give them a trial of a hyaluronic acid series to see if we can get months. But if we don't get months, then I just say injections probably are not part of our management tool. But back
There are
here.
a couple of practitioners in the city who are injecting plasma-enriched or platelets and stem cells into knees with osteoarthritis. What do you tell patients when they ask about it? What do you think about that?
So when I looked at, so PRP and stem cells for injecting into the knee with osteoarthritis, and it's interesting, those clinics that I've seen, and it seems like this has been a big thing over the last year. It seems like they're all radiologists that are doing it, which is kind of interesting, treating the knee arthritis, but whatever. So about 3 years ago, I looked at studies on sclerotherapy, PRP. I can't recall going over stem cells, but there was lots of anecdotal. You know, you'd find a case report, you'd find a case series of 2 or 3 people. You couldn't find a good either retrospective study or a randomized controlled trial. So I don't know if things have changed. I just don't have that information in front of me right now. I don't know if there's good studies out there now. My guess is that they're probably not. But you know, I'm a little leery of it. Again, if a patient came in and said, I had this injection, I've done great for a year, should I get it again? I'd say, well, that's probably reasonable. I'm always curious what they're paying out of pocket and things like that. And you know, if you're not getting relief, but you need to do 6 of these injections and you need to pay for each one, and it's like, I don't know how much that's on the up and up. Great question. Yes?
Do you think physical therapist is necessary for the resistance training program and other therapy, or can you just give handouts and a job?
So there's a great question. Is a physical therapist necessary, or can you just give handouts? So the answer to both of those is yes. It depends on the patient. Patient that knows their way around the gym, sometimes it's just giving them information. So in Epic, I've got my little smart phrases and things like that, and I've got lists of exercises that I want the patients to do in the gym. For the spine, we've even got what their goals should be based on percentages of ideal body weight on certain machines and things like that. Now, if I'm going over that with a patient and I'm getting this deer in the headlights look, I'm probably going to move them over to PT, and I'm going to have the PT. And what I tell the patient is that I want the PT to act like a well-educated personal trainer. I want them to teach you what to do, and I want you to go out on your own and do it. One of the other things I tell patients is all physical therapists mean well. Not all physical therapists are good at prescribing exercise. If I go spend a lot of time in clinic telling the patient you need to gain strength, gain endurance, gain flexibility, don't be fearful about activities, hurt doesn't mean harm, it's okay to go out there and do things, and I send them off to the therapist, and the therapist says, oh my gosh, you've got pelvic obliquity and your hip's dislocated, and lie down here and let me do massage and heat and ultrasound, and we're going to get you back in alignment. I've just shot myself in the foot. And that patient's getting conflicting advice about what to do, and it's kind of that active advice versus more of a passive advice. So I'm very specific in who I use for my physical therapists, and I really want people to take the approach like a well-educated personal trainer and teach the patient what to do. And it's interesting, if we were talking spine here, we'd talk about the studies that talk about pain contingent versus non-pain contingent physical therapy programs. And pain contingent means it hurts, you better stop. And the non-pain contingent, patients may have pain during therapy, but the therapists are trained to say, I'm sorry that's hurting, give me 10 more reps. The non-pain contingent programs in the spine literature are associated in the long run with decreased pain because they're actually gaining strength, endurance, flexibility. You got to get the function before you get the pain to improve. So I'm very specific in who I use. Somebody knows their way around a weight room. It may be advice, and for some patients, because they've heard for so long that hurt means harm, sometimes it's just advice in your office. Listen, you can go do things. Hurt doesn't mean harm. Use your common sense, but it's okay for you to go out and take a hike and things like that. And if it's worth it to you, I took a hike, my knee hurt. It was a great hike. I took some ibuprofen and iced it afterwards. I'm happy. Good for you, right? You made a reasonable decision based on quality of life. I'm going to get back here. Yes.
Just one comment. You mentioned heel wedges and orthotist. I think you could spend a lot of money for a heel wedge at an orthotist, or you could go to your shoemaker and have him make just like a 3/8 inch lateral heel and sole wedge on a normal shoe insert, sort of a pattern, and he'll do it for 10 or 15 bucks.
Yeah.
And you only need it in the affected leg. It's not going to throw you off balance if you don't have it in the other leg, for instance. So the orthotist will charge you $200 to do that $10, $15 shoemaker operation.
So great comment. The comment is, do you need to go to an orthotist to get a heel wedge or things like that? And I absolutely agree. I've worked with an orthotist for about 15 years now that I know when I send that patient to the orthotist, they're not going to get this huge bill. By the same token, when the orthotist and I are seeing a patient in clinic and we're talking about, let's say, custom orthotics, both of us will usually recommend to that patient, go to REI, go to Dick's, try Superfeeder and over-the-counter orthotic first and see if that does it for you, because that'll cost you 40 bucks as opposed to the 400 a pair that the orthotists charge. But I agree with you. You can do very, very simple things very inexpensively, and shoe shops and kind of the cobbler bills and things like that are great at doing the heel wedges. Yes, sir.
I've been seeing a lot of lidocaine being used in patch form
Yeah.
for joint pain and back pain. What's your opinion?
You know, I've seen a lot of that too, and I generally, that just hasn't been kind of in my list of things that I routinely do. And I guess where I'm seeing it is patients are coming in now and saying, can you fill this for me? So I don't know if they're just doing a lot of advertising blitz or what's going on with it. I also know that if we do fill it, usually then about a week later we'll get the insurance denied it. So it seems like insurance doesn't like to pay for it. I would be, now again, anything that works, that's fine, right? If somebody puts a lidocaine patch on their knee and says, my knee's great and I'm doing everything, I'd say more power to you. My initial suspicion, if I'm looking at all my options, a lidocaine patch for knee arthritis would not be in my upper group or mid group. I think it would be useful for neuropathic pain, things like that, but I'm just going to have a hard time kind of logistically figuring out how is that lidocaine on the skin actually getting down to the knee joint, right? So you know, anything on a one-time basis that seems to be very effective, I'll help support the patient on that, but it's just not something I would routinely do.
We should probably stop.
Okay.
Yeah, we'll take the other questions at the podium.
Yeah.
Thank you. Still on there's the masters.
That's all right.
That's awesome. Thank you so much.
Oh, you're
Sorry
quite
about all
welcome.
the snafu.
Oh, no, we've finally got it out.
Thanks very much. Just a